Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 213 of our Pharmacotherapy MCQ series, which majors in infectious diseases. And the first question reads, KTN, a 42-year-old homeless man was admitted for evaluation of several days of fever and progressive jaw pain and neck swelling. On examination, KTN was found to have poor dentition and significant induration and erythema along his mandible and extending down his neck. Neck CT scan showed significant soft tissue swelling and phlegm. ENT was consulted and KTN was started on antibiotics. So my question to you is, of the following options, what is the least appropriate choice for KTN's initial medical therapy? Is it A. ampicillin sulbactam, or B. ceftriaxone plus metronidazole, or C. meropenem, or D. penicillin G plus clindamycin, or is it E. vancomycin? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is E. vancomycin. I will explain why. KTN is presenting with Ludwig's angina, likely from an odontogenic source. He should receive broad empiric coverage for oral flora, including coverage for viridans group Streptococci, Actinomyces species and anaerobes, including Fusobacterium, Prevotella and Peptostreptococcus, until culture data are available to help guide selection of therapy. Vancomycin monotherapy would not provide coverage for gram-negative anaerobes. Please proceed to the next question. And the next question reads, SMO, a 32-year-old woman was readmitted to the hospital 3 days after having had a spontaneous abortion at 18 weeks gestation. On examination, SMO had a temperature of 38.1 degrees Celsius, a pulse of 132 beats per minute, a blood pressure of 85 systolic 60 diastolic, diffuse abdominal tenderness to palpation, and significant abdominal and lower extremity swelling. Blood cultures were obtained and she was started on antibiotics. Within a few hours, her blood cultures were growing gram-positive rods. So my question to you is, what is the most likely cultured organism? Is it A. Clostridium botulinum, or B. Clostridioides difficile, or C. Clostridium sordali, or D. Clostridium striatum, or is it E. Clostridium tetani? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Clostridium sordali. I will clarify why. Clostridium sordali infections can develop following childbirth or after gynecologic procedures, and can also be seen with contaminated lacerations or in intravenous drug users. Patients may not present with high fevers, but may have significant leukemoid reaction and hemoconcentration, as well as edema on examination. Please proceed to the next question. And the next question reads, JGG, a 45-year-old firefighter, who just returned from working on a forest fire in California, is now presenting with malaise and progressive, ascending, bilateral lower extremity weakness. JGG denies having had any fever or headache. On examination, JGG had bilateral lower extremity hypotonia, but his sensation was intact. JGG went on to develop respiratory failure that required intubation and mechanical ventilation. CSF studies and imaging of JGG's brain and spine were normal. So my question to you is, what is the most likely cause of JGG's symptoms? Is it A. Guillain-Barré syndrome, or B. myasthenia gravis, or C. poliomyelitis, or D. tick paralysis? Or is it E. West Nile virus? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. tick paralysis. I will clarify why. Tick paralysis causes an ascending, flaccid paralysis that can progress to respiratory failure and can be associated with cranial nerve involvement. Level of consciousness and sensation typically remain intact. Fever and headache are not typically seen, and the CSF studies are normal. Symptoms typically improve rapidly once the tick is found and removed. Please progress to the next question. And the next question reads, WOA, a 47-year-old male with advanced HIV and poor adherence to therapy presented to clinic complaining of an intensely pruritic rash. WOA is currently homeless. WOA's last CD4 count was 25 per microliter and he is not currently taking medication for HIV. On examination, WOA is cachectic and has multiple areas of excoriation on his skin with several lichenified and crusted patches. What is the most likely cause of WOA's rash? Is it A. atopy, or B. bacterial infection, or C. fungal infection, or D. parasitic infection, or is it E. viral infection? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Parasitic infection. I will clarify why. WOA has crusted, or Norwegian, scabies. This form of scabies is seen in immunocompromised individuals and can be highly contagious. Treatment with permethrin and ivermectin is recommended. Please advance to the next question. And the next question reads, JBO, a 56-year-old woman with acute myelogenous leukemia, status post-bone marrow transplant, and still awaiting engraftment, was found to have a black, ulcerating lesion on her leg. JBO is still neutropenic and has been febrile for the last few days. Carefully scrutinize the photo in this slide before answering the question below. So my question to you is, what is the most likely cause of JBO's skin lesion? Is it A. ecthyma gangrenosum, or B. erythema multiforme, or C. erythema nodosum, or D. leukocytoclastic vasculitis? Or is it E. Sweets syndrome? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Ecthyma gangrenosum. I will explain why. JBO likely has ecthyma gangrenosum, which is most commonly seen in immunocompromised hosts and is a manifestation of septicemia with Pseudomonas aeruginosa. Lesions typically start as erythematous or purple macules that become bullous and hemorrhagic and then rupture to reveal a centrally gangrenous ulcer with a black eschar. Please proceed to the next question. And the next question reads, ABO, a 5-year-old boy who recently emigrated from Mexico was brought to the doctor because of left axillary swelling. ABO's mother said that the swelling had been gradually worsening over the last few months, but the child was otherwise feeling well and had had no fevers or discomfort related to the swelling. On examination, ABO was found to have a several centimeter area of firm swelling under his left arm with some overlying ulceration. Closely scrutinize the photo in this slide before answering the next question. So my question to you is, of the listed mycobacteria, which would be the most likely cause of ABO's lymphadenitis? Would it be A. Mycobacterium abscessus, or B. Mycobacterium fortuatum, or C. Mycobacterium gordonii, or D. Mycobacterium marinum, or would it be E. Mycobacterium tuberculosis? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is E. Mycobacterium tuberculosis. I will justify why. Of the listed species of mycobacteria, Mycobacterium tuberculosis would be the most likely cause of lymphadenitis. Amongst the atypical mycobacteria, Mycobacterium avium complex and Mycobacterium scrofulosum are also important considerations. Mycobacterium bovis can also cause lymphadenitis, but is typically associated with cervical lymphadenitis and in the context of ingestion of unpasteurized dairy products. Please proceed to the next question. And the next question reads, SWN, a 23-year-old man presented to the HIV clinic complaining of painful swellings in his groin. On examination, SWN has no genital ulcers or chancres, but he has large bilateral inguinal lymphadenopathy. You suspect SWN has a sexually transmitted disease. Carefully scrutinize the photo in this slide before answering the next question. My next question to you is, what is the most likely diagnosis? Is it A. chancroid, or B. genital herpes, or C. granuloma inguinale, or D. lymphogranuloma venereum, or is it E. syphilis? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Lymphogranuloma venereum. I will explain why. The photograph depicts the groove sign of lymphogranuloma venereum, abbreviated as LGV, wherein groups of enlarged inguinal lymph nodes are cleaved by the inguinal ligament. Please proceed to the next question. Pause the video and closely scrutinize the photographs shown below. Which of the following entities is depicted by the photographs shown in the previous slide? Is it A. Candida endophthalmitis, or B. HSV keratitis, or C. ocular histoplasmosis, or D. viral conjunctivitis, or is it E. zoster ophthalmicus? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. HSV keratitis. I will justify why. The photograph demonstrates dendritic keratitis associated with HSV. Branching epithelial lesions are seen on examination. Please proceed to the next question. And the next question reads, TTL, a 25-year-old intravenous drug user presents to clinic with several days of fever as well as decreased visual acuity and reddening of her eye as shown in the photo in this slide. Carefully scrutinize the photo in the next slide before answering the next question. Which of the organisms listed below is the most likely cause of TTL's systemic infection? Is it A. Candida albicans, or B. Haemophilus influenza, or C. Pseudomonas aeruginosa, or D. Staphylococcus aureus, or is it E. Staphylococcus epidermidis? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Candida albicans. I will explain why. TTL likely has fungal endophthalmitis caused by Candida albicans. On examination, she has hypopyon and also has fungal balls visible near the periphery of her iris. IV drug users are at particular risk to develop endogenous endophthalmitis. Initial evaluation and management should include blood cultures and systemic and intravitreal antibiotic therapy, as well as echocardiography to assess for infective endocarditis. Please proceed to the next question. Pause the video and carefully scrutinize the photo below before answering this question. What is the most likely sexually transmitted disease to be the cause of the findings in the photograph? Is it A. chlamydia, or B. gonorrhea, or C. HIV, or D. human papillomavirus? Or is it E. syphilis? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is E. syphilis. I will clarify why. The photograph shows significant keratitis and hypopyon as seen with anterior uveitis. Syphilis can have a variety of ocular manifestations including, anterior uveitis, which is most commonly seen during secondary syphilis, posterior uveitis and retinitis, and interstitial keratitis that is a late sequela of congenital infection. Herpes simplex virus could also be considered in the differential diagnosis. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 214.